This 12th program in the video seminar series on echocardiography, presented by the American College of Cardiology and the Mayo Clinic, concentrate on three procedures: contrast echocardiography, echo-directed pericardiocentesis, and transesophageal echocardiography. To thank their professional and paramedical colleagues. In particular, 5 individuals have played paramount roles: Mr. Phil McAteer in video communications, David Smirk for medical graphics and animation, Mr. Vernon Weber for echo and technical coordination, Charlene Tree for audiovisual and echo coordination, and Dr. Bill Edwards for pathologic specimens and tomographic correlations. The first technique to be discussed is contrast echocardiography and its clinical applications. We have purposefully avoided experimental applications. Many of these techniques do show clinical promise, but at this time are not being applied and thus are avoided in this. This 12th program in the video seminar series on echocardiography, presented by the American College of Cardiology and the Mayo Clinic, concentrate on 3 procedures: contrast echocardiography, echo-directed pericardiocentesis, and transesophageal echocardiography. Over the past 2 years, a number of individuals have contributed a great deal of time to the production of this 12-part series. Doctors Miller, Seward, and Tajik would like to thank their professional and paramedical colleagues. In particular, 5 individuals have played paramount roles: Mr. Phil McAteer in video communications, David Smirk for medical graphics and animation, Mr. Vernon Weber for echo and technical coordination, Charlene Tree for audiovisual and echo coordination, and Dr. Bill Edwards for pathologic specimens and tomographic correlations. The first technique to be discussed is contrast echocardiography and its clinical applications. We have purposefully avoided experimental applications. Many of these techniques do show clinical promise, but at this time are not being applied and thus are avoided in this particular presentation. 2 references are suggested, one from the Mayo Clinic from 1975 and is the first clinical application of contrast echo in M-mode echocardiography. The second is a comprehensive textbook on the subject by Meltzer and Roulant. A number of echo contrast agents have been utilized. These include saline, blood, indocyanine and green, radiographic contrast, which is usually sonicated, and some newer agents which are yet to be released. The procedures which follow utilize indocyanine and green, followed by a flush of saline. An inexpensive echo contrast agent is indocyanine and green. The technique utilizes a 3-way stopcock connected to the patient, a flushing port for the indocyanine and green, usually injected 1 or 2 cc's, followed by a flush of saline in the amount of approximately 5 cc's. Indocyanine and green is commonly used in a cardiac catheterization laboratory. The dose is usually 5 milligrams per cc. It is injected through the sidearm of the 3-way port, followed by a flush of saline. 2 assistants are required. This picture exemplifies the typical setup. The examiner, who sits at the right hand of the patient, observes the echocardiographic picture. 2 assistants are positioned at the patient's arm with the 3-way stopcock. Upon instruction, the indocyanine and green is injected, followed by the flush of saline. Within this discussion, we talk about the unique application of orthostatic contrast injections. Here with the patient in the upright position, contrast injected into the left antecubital vein. With the advent of color flow Doppler, clinical indications for contrast echocardiography have actually decreased. However, some applications still persist, such as the right-to-left shunts, particularly for orthodeoxia, which is a positional right-to-left shunt, patent foramen ovale, or special applications such as myocardial perfusion or during cardiac catheterization. This first example is of a patient studied for source of embolism with transesophageal echocardiography. This is a 4-chamber view. In real time, note that the valve of the fossa ovalis appears as a thin mobile membrane in the middle of the atrial septum. The right atrium, which will opacify first with a contrast echo, then goes into right ventricle, and no contrast is visualized in left atrium or in left ventricle. Upon repeating the injection, note that the right atrium and right ventricle opacify. However, in the area of the fossa ovalis, there is washout from the inferior vena cava blood. This should not be confused with shunt. As previously stated, contrast echocardiography is less frequently utilized in congenital heart disease today. However, one lesion, a left superior vena cava, either to the coronary sinus or left atrium, is an exception. This is an example of a 13-year-old boy with a left superior vena cava to the coronary sinus. This is a subcostal examination looking at the right atrium and right ventricle. Notice a dilated coronary sinus entering the right atrium. Following a left antecubital vein injection of indocyanine, green, and saline, there will be opacification of the coronary sinus, confirming communication of the left upper extremity to the coronary sinus through a left superior vena cava. This boy had a ventricular septal defect, thus dye does appear in the left ventricle. 2 lesions where contrast echocardiography is very helpful in the assessment of right to left shunt include orthodeoxia and pulmonary AV fistula. The next 2 examples are that of orthodeoxia, the first in a 49-year-old female who is breathless and dyspneic on exertion. In this apex up 4-chamber view, the right-sided chambers are to your right. The first injection is with the patient recumbent, and the contrast will initially appear in right atrium and then into right ventricle. Note that there are occasional bubbles appearing in the left ventricle and left atrium, but there is no appreciable right to left shunt. These patients shunt in the standing position with injection into right atrium. Note that there is contrast into left atrium and left ventricle consistent with right to left shunting. This predominance of shunting in the upright position can be accentuated by a Valsalva maneuver. Here the patient strains, then injection into right atrium and right ventricle is followed by a more dramatic right to left shunt following the Valsalva release. The next is a dramatic example of orthodeoxia in a 64-year-old man post-pneumonectomy. The post-pneumonectomy patient is the typical syndrome in which there's predominant shunting in the upright position. Firstly, in the supine position, contrast enters the right atrium and right ventricle, and there is some contrast into the left-sided structures, indicative of a small amount of right to left shunting. Still in the supine position, note that the contrast enters right atrium, right ventricle, and then there is contrast entering from the left atrium into left ventricle consistent with shunt. In the standing position, there's a more dramatic right to left shunt. First, the contrast appears into right-sided chambers and then dramatically fills the left-sided chambers. Thus, in the standing position, there's a dramatic accentuation of the right to left shunt. That contrast injection is repeated. First the right-sided chambers and then the dramatic filling, first of the left atrium and then left ventricle, consistent with orthodeoxia, or right to left shunting with standing. Orthodeoxia should be suspected in any patient with inordinate standing desaturation. Contrast echocardiography is extremely sensitive in picking up pulmonary AV fistula. This is an example of a 55-year-old woman who is cyanotic. With the apex up 4-chamber view, contrast will initially appear in the right atrium and right ventricle. Then after 4 or 5 cardiac cycles, contrast appears in the left-sided chambers. This is consistent with a pulmonary AV fistula. A second injection will again show opacification of the right atrium, followed by opacification of the right ventricle. Note the delay in appearance in the left atrium. This is consistent with transit through the pulmonary bed and a pulmonary AV fistula. Contrast echocardiography is extremely sensitive in picking up these right to left shunts and can localize them in anticipation of angiographic confirmation. An increasing application of contrast echocardiography is in conjunction with transesophageal echo. This is an example of a search for patent foramen ovale. This is an apex down, four-chamber view with transesophageal echo. Note that the foramen ovale appears as a thin membrane separating left and right atrium. With a Valsalva maneuver, note that the foramen ovale moves erratically, and that with contrast injection, a marked opacification initially appears in right atrium and then left atrium, consistent with right to left shunt. This is a longitudinal transesophageal scan. The transducer is posterior to left atrium and right atrium, with the atrial septum and valve of the fossa vallis separating those two chambers. The ascending aorta is located anteriorly. Within the right atrium, the eustachian valve appears as an undulating membrane. The valve of the fossa vallis passes between the two atria beneath the ascending aorta. The ascending aorta is cut in oblique section, and a portion of the right pulmonary artery is posterior to the aorta. The superior vena cava enters this right atrium. Following injection of contrast, note that there is a negative contrast effect through the patent valve of the fossa vallis. No right to left shunt was visualized. With a more magnified view of the valve of the fossa vallis, patient is performing a Valsalva maneuver. Following contrast injection and release, note the transient right to left shunt across the patent foramen ovale into left atrium. This is an extremely sensitive echocardiographic technique for the detection of a patent foramen ovale. Over the past few years, contrast echocardiography is used less frequently for the detection of left-to-right shunt. However, with the advent of transesophageal echocardiography, contrast techniques have been used with increasing frequency. This is a longitudinal transesophageal scan in a 58-year-old male with a very small atrial septal defect. The atrial septum appears to be interrupted by a small defect. The defect is measured to be approximately 1 centimeter in diameter. The arrow is in the left atrium. With subsequent contrast injection, dye will initially appear in the right atrium through the superior vena cava. Note the negative contrast effect confirming the small left to right shunt across this atrial septal defect. The next major procedure to be discussed is echo-directed pericardiocentesis. Two pertinent references include one by Callahan et al. In the American College of Cardiology discussing echo-guided pericardiocentesis in 117 patients. The second is by Kopetsky et al. And discusses percutaneous pericardial catheter drainage by echo technique. In Callahan's review of the literature of 341 patients undergoing blind pericardiocentesis, the complication rate was 12% and the mortality 6%. This led to the development of echo-directed pericardiocentesis. In a review of 450 patients, Seward et al. Found major complications in only 1% of patients, minor complications in 3%, and no mortality. Thus, echo-directed pericardiocentesis has become the technique of choice in this interesting application of echocardiography. There are three simple prerequisites to the echo-directed pericardiocentesis. Firstly, two-dimensional echocardiography is utilized to find that position on the chest wall where pericardial fluid is closest to the transducer. Secondly, two-dimensional echocardiography is utilized to determine the best entry point which avoids underlying vital structures. And thirdly, the site is marked prior to beginning the actual procedure. This still frame shows a large pericardial effusion around the apex of the heart, both anteriorly and completely off the apex. Note the large echo-free space which would totally avoid the underlying heart. This is better illustrated by turning the transducer at 90 degrees off the apex of the heart. Note that there is about 3 centimeters between the chest wall and the pericardial cavity and 9.5 centimeters of pure echo-free space which avoids all underlying structures. This is the ideal entry point. This slide illustrates the fallacy of using steel needles with electrocardiographic monitoring. This is a swinging heart. Note that upon entering the pericardial space, with the next cardiac cycle, the heart would literally impale itself upon the needle. To avoid this phenomenon, the echocardiogram would recognize the most appropriate space for entering at the apex of the heart, away from the vital structures such as heart, liver, or lung. In the Mayo Clinic series on echo-directed pericardiocentesis, the entry site was less commonly subcostal and more commonly chest wall. The anterior axillary line, parasternal, and midclavicular spaces were often utilized. Because ultrasound does not traverse air-filled lung and confidently avoids underlying vital structures, unconventional sites can be frequently or more commonly utilized. This is an example of a tray suitable for echo-directed pericardiocentesis. Multiple Teflon sheath needles are utilized, large syringe for withdrawing fluid, suitable tubing with 3-way stopcock, scalpel, sterile 4x4s, steri-drape, multiple syringes, culture tube, and xylocaine anesthetic. Because the ideal entry site localizes pericardial fluid closest to the chest wall, 6 to 8 centimeter length 16-gauge Teflon sheath needles can be utilized for the pericardiocentesis. If extended pericardial drainage is deemed necessary, a wire is inserted through the Teflon sheath. After withdrawal of the small sheath, a larger 7 or 8 French sheath is introduced into the pericardial sac. Through this sheath, a 60-centimeter pigtail catheter is inserted. Intermittent drainage is preferred. Intermittent installation of heparinized saline will keep the catheter patent. This will be an example of pericardiocentesis in a 50-year-old woman with metastatic breast carcinoma who presents with large pericardial effusion. The initial echocardiogram performed at bedside localizes the effusion, vital structures, and in particular, the point on the chest wall where the fluid is closest to the transducer. Note that in this particular transducer position, there's a small echo-free space anteriorly. Similarly, in the short axis view, there's a larger space posteriorly, a small anteriorly located space. Certainly not an ideal position for the pericardiocentesis, as the needle would enter close to the shifting heart. The M mode shows the swinging heart within the pericardial sac. A true apical view also shows that the apical impulse would be very close to any transducer entry site and thus would not be an ideal position or direction in which to pass a pericardiocentesis needle. This is the subcostal position. Note the large expanse of liver between the transducer and the pericardial space. This also, crossing over the liver capsule, would be a less than ideal position. Note that in this transducer position on the precordium, that a portion of the apex is still visualized. However, there is a large echo-free space medial. This is the ideal entry site for pericardiocentesis. Note that this site is selected by the examiner and then confirmed repetitively with the echo probe. An indelible marker is utilized to identify that position on the chest wall most suitable for entry. This places the pericardial fluid close to the chest wall. The examiner repeatedly determines the best angle of entry into the pericardial sac. The chest wall is then scrubbed with antiseptic solution and appropriately draped to begin the pericardiocentesis procedure. Remote echocardiographic examination can be performed. A sterile sheath covers the entry site. This particular woman has had bilateral mastectomies and is known to have metastatic carcinoma. The tap is primarily for diagnostic purposes to confirm the suspicion of metastatic carcinoma. Local anesthetic is instilled into the chest wall over an appropriately identified rib space. The fluid is actually close enough to the chest wall that the small probing needle will actually enter the pericardial sac through the anesthetized space on the chest wall. The larger 16-gauge needle is then passed over the rib space into the pericardial sac. Immediately upon entering the pericardial sac, the Teflon sheath is advanced and the steel needle withdrawn. Pericardial fluid pressure is obtained with manometry. In this case, a very low pressure of 5 to 6 centimeters of water. This patient was minimally symptomatic with a large pericardial fluid accumulation. A three-way stopcock and extender are attached to the needle. Fluid is withdrawn through the small Teflon sheath. Notice that the patient is comfortable and at ease throughout the examination. The fluid is collected into a vacuum bottle at the bedside. The withdrawal of fluid or position of the needle can be monitored by remote echocardiographic examination. Note, from the subcostal position, all of the pericardial fluid has now been cleared following this therapeutic pericardiocentesis. The Teflon sheath is then removed. The site will be covered with antiseptic solution and Band-Aid applied. This reasonably atraumatic procedure is well tolerated by almost every patient. Little anesthetic is required and very little risk to the patient, even with small accumulations of pericardial fluid. At the end of the examination, further echocardiographic confirmation can be obtained. Note the slowing of heart rate in this particular patient and the absence of any significant residual pericardial fluid. The second example is a pericardiocentesis in a symptomatic 50-year-old man who is in clinical cardiac tamponade. The pericardiocentesis is performed both for therapeutic as well as diagnostic reasons. Because of the clinical presentation of cardiac tamponade, it's deemed necessary that implantation of chronic pericardial drainage would be most prudent at this time. The most suitable entry site is identified on the left chest wall. This site is repeatedly identified, the angle of entry confirmed. An appropriate rib space is marked on repeated examination before the chest wall is then prepped with sterilizing solution. Remote echocardiographic examination can be performed at any time during the actual centesis procedure. The chest is appropriately draped. Note that the patient is allowed to assume the most comfortable position, but is then not allowed to move during the remainder of the examination. Because small needles are utilized, the patient usually can remain in a comfortable position and tolerate the procedure without further discomfort. Note that the site is marked clearly on the chest wall. Local anesthetic is infused into the superficial tissues of the chest and over the top of the appropriate rib through which the pericardiocentesis will be performed. The angle of entry is confirmed repeatedly. In fact, during local installation of anesthetic, frequently the pericardial sac is entered and confirmed. In the clinical setting of a large symptomatic pericardial fluid accumulation, protracted pericardial drainage was deemed necessary. Thus, pericardial sheath was made ready, along with a short indwelling pericardial catheter. The pericardial sac is entered with a 16-gauge Teflon sheath needle. Note in this circumstance, the sheath is advanced atraumatically. A manometer reading of the pericardial pressure is obtained. In this example, the pericardial pressure is quite elevated, consistent with the symptomatic presentation. Note that the fluid level is in the range of 23 to 22 centimeters of water. Before any more fluid is drained, a wire is passed through the Teflon sheath into the pericardial sac. The small sheath is then removed, and the larger sheath is then slipped over the wire and then with a Seldinger technique advanced into the pericardial sac. This usually places the sheath in the posterior pericardial sac. In this particular example, an 8 French sheath was utilized, and a 60 centimeter 8 French pigtail catheter is to be introduced into the pericardial sac. Note that the pericardial fluid is bloody. You can confirm the position of either the needle or sheath with injection of blood, saline, or indocyanine and green. However, in this circumstance, the assurance of the introduction did not require further documentation of position. Using a 3-way stopcock system, the pericardial fluid is then drained by hand and collected in a receptacle at the bedside. At the end of the procedure, the introducing sheath is withdrawn and the side arm excised. Only the pigtail catheter remains within the pericardial sac. The site is then dressed like any other indwelling catheter system. Sterile solution, appropriate sterile drapes, and dressings are applied. A 3-way stopcock is attached to the catheter, and the catheter is intermittently filled with sterile heparinized saline to avoid clotting. The end of the catheter is conveniently covered with a sterile glove, which allows intermittent access to the 3-way stopcock without contaminating the remainder of the catheter. The catheter is then secured to the chest wall. The echocardiogram can be intermittently repeated to monitor cardiac function. The next procedure to be discussed is transesophageal echocardiography. This technique has made a substantial impact on the echocardiographic field in the last 2 years. This slide shows the increasing impact of transesophageal echocardiography at the Mayo Clinic in the first 2 years of outpatient application. This slide shows the clinical applications of transesophageal echocardiography in the first 1,000 patients at the Mayo Clinic. The most frequent application was in the study of thromboembolism or masses in 28% of patients, prosthetic valve dysfunction in 17%, native valve dysfunction, particularly mitral regurgitation, in 16%, endocarditis and its complications in 11%, thoracic aortic pathology, particularly aortic dissection, in 7%, critically ill patients, particularly in the coronary care unit and emergency room, 7% of patients, and congenital heart disease makes up approximately 5% of patients. This is a typical echocardiographic endoscopic transducer. The elements are mounted at the tip of the transducer. There are knobs which allow movement of the scope tip and transducer. The electronics exit through the handle. The actual scope is approximately 100 centimeters in length, 9 millimeters in diameter, and is marked in centimeter markings. The typical tip is approximately 11 millimeters in diameter. The shaft about 9 millimeters in diameter. This is a typical adult-sized endoscope. This is a monoplane scope, imaging in a single horizontal plane. This is a biplane transducer with a horizontal plane distally and a longitudinal plane mounted more proximally on the scope tip. Both monoplane and biplane will be discussed. Terminology of scope movement include advancement, withdrawal, and advancement of the scope, which allows superior and inferior structures to be visualized. The scope can be rotated to image medial or lateral structures in the horizontal plane, flexed anteriorly or anteflexion, flexed posteriorly or postreflexion, medial flexion, and lateral flexion. Each movement allows the transesophageal transducer to image different portions of the heart. All four movements are possible with each commercially available instrument. In the horizontal imaging plane, typically the plane is rotated for medial and lateral imaging, anterior flexed for more basal structures, and retroflexed to image more four-chamber or frontal views. In the longitudinal plane, rotation images lateral and medial structures. Lateral and medial flexion image short or long axis views of the heart. Anteflexion and postreflexion allow superior and inferior structures to be imaged. This is a typical transesophageal echocardiographic exam room. The table should be height adjustable for ease of the examiner. The echocardiographic instrument is at the head of the table to the patient's left. At the head of the table is an automated blood pressure recording device, suction, and pulse oximeter for monitoring patient's saturation. The assistant sits at the head of the table, monitoring patient and assisting during the exam. Drugs are variably used during the transesophageal examination. In our own experience, 100% received local pharyngeal anesthetic, 98% received an anticholinergic for drying agent, 70% received mild general sedation, 15% subacute bacterial endocarditis prophylaxis. Training of the transesophageal echocardiographic physician can be broken into two parts. The first, esophageal intubation. We suggest 30 or more intubations under the tutelage of a gastroenterologist, experienced transesophageal physician, or for intraoperative studies, an anesthesiologist. The second component of training is learning tomographic anatomy. For the inexperienced, basic echocardiography takes 6 to 12 months. For transesophageal anatomy, we refer you to literature and experience, usually 30 to 50 transesophageal exams. This segment illustrates esophageal intubation in the outpatient environment. The patient is rotated to the left in a decubitus position. Comfort is obtained, both warmth as well as a supporting pillow behind the patient. Usually the upper leg is positioned anterior to the lower to assure that the patient remains in the decubitus position. A minor securing restraint assures the patient will stay in the left decubitus position. Local pharyngeal anesthetic is administered in the form of an aerosol. Usually 1 or 2 applications are necessary. The patient is instructed to roll the anesthetic in the throat and then swallow. If drying or sedation is utilized, it is given through an indwelling antecubital venous entry site. We also use this site for contrast echocardiography, which has been illustrated earlier in this tape series. In this particular patient, we used approximately 2.5 milligrams of midazolam. The patient is sedate but cooperative. The scope tip is lubricated with KY jelly. The technique illustrated in this examination is a digital entry technique. The left index finger is inserted to the back of the tongue. The scope is placed beneath the index finger and then forced downward, having the patient swallow once. The scope usually slips into the esophagus without appreciable resistance. A bite guard is then placed between the teeth to protect the electronics of the endoscope. The assistant monitors the patient, assisting him with breathing, suction if necessary. The examination takes approximately 15 minutes. This allows for appropriate basal, four-chamber, transgastric, and aortic views to be obtained. Presently, approximately 1% of patients do not tolerate esophageal intubation in our echocardiography laboratory. A gastroenterologist can be helpful in these circumstances. At the termination of the examination, the scope is washed and cleaned of adherent material and then sterilized with a glutaraldehyde solution. The transesophageal examination usually begins with basal short axis and frontal four-chamber views. The scope is advanced into the esophagus approximately 25 centimeters. In the horizontal plane with progressive antiflexion of the transducer, short axis views are obtained, also by slight withdrawal, views of the pulmonary artery. With retroflexion of the scope, frontal four-chamber views are obtained. Advancement of the scope assists in these views. This is an anatomic specimen cut in the basal short axis view. The esophagus is located posteriorly. Immediately adjacent, the descending thoracic aorta. The esophagus is in immediate contact to the left atrial cavity. The most central structure is the aorta and aortic valve cusps. To the right of the image is a pulmonary valve, the left atrial appendage, and the left upper pulmonary vein. To the image left is the right upper pulmonary vein. The transverse sinus is posterior to the aorta and exiting from the left coronary cusp, the left coronary artery. To the left of the image is the right atrial appendage, and more superiorly, the superior vena cava. This is a transesophageal echocardiogram of a basal short-axis view. The transducer is adjacent to the left atrial cavity. The central structure is the aortic valve, which is usually cut obliquely. To the right of the image is the pulmonary valve. A portion of the left coronary artery is visualized, the left atrial appendage, the left atrial cavity, and lastly, the left upper pulmonary vein. This segment illustrates a potential pitfall. Posterior to the pulmonary artery and aorta is the transverse sinus, a pericardial reflection. Occasionally, the tip of the atrial appendage appears as a tumor-like structure or ovoid structure. This is actually the normal left atrial appendage caught in short axis within the transverse sinus. This is an anatomic specimen cut in the frontal four-chamber view. The esophagus is posterior and immediately adjacent to the descending thoracic aorta. Next is the left atrium. The pulmonary veins are visualized posteriorly. The orifice of the mitral valve, the anterior papillary muscle, the ventricular septum, right ventricular cavity, right atrium, and in the floor of right atrium, the orifice of the inferior vena cava. The atrial septum separates the left atrium and right atrium. This is a transesophageal echo in the frontal four-chamber plane of view. The transducer is immediately adjacent to the left atrial cavity. The mitral valve orifice is best imaged in this plane of section. The left ventricle is visualized beneath the mitral valve leaflets. In a high percentage of normal patients, there is trivial mitral valve regurgitation as illustrated on this color flow image. With preferential visualization of the atrial septum, the right atrium, right ventricle, and tricuspid valve are visualized. The thin portion of the valve of the fossa vallis separates the fatty limbus of the atrial septum. Contrast echocardiography in this position opacifies the right atrium and subsequently right ventricle. Note that there is no contrast in the left-sided chambers. The next sequence illustrates the technique of imaging the pulmonary veins. Also note the large fatty annulus of the tricuspid valve, which is a normal variant and should not be confused with tumor. With anteflexion and withdrawal of the scope, the mitral valve and subsequently the left atrial appendage are visualized. Superior to the left atrial appendage is the left upper pulmonary vein. The plane of tissue which separates the left upper pulmonary vein and atrial appendage often has a bulbous appearance and should not be confused with tumor. Rotating the transducer rightward will demonstrate the right upper pulmonary vein. The scope is advanced to visualize the right lower pulmonary vein. Subsequent withdrawal and advancement will image upper and lower pulmonary vein. The scope is now being turned leftward to again image the left upper pulmonary vein. The next animation segment illustrates the technique of transgastric imaging from short and long axis projections. The scope is advanced to approximately 40 centimeters from the incisors, antiflexed into the fundus of the stomach. Short axis views can be obtained in a bread loafing fashion by progressive antiflexion and retroflexion. Longitudinal views can also be obtained from the transgastric position. This anatomic specimen is cut in the transgastric short axis view. It's viewed from apex toward base, with the anterior wall to the top of the image, posterior wall to the bottom, left ventricle to the right, right ventricle to the left, and the right ventricular outflow tract anteriorly. In order to obtain this preferred anatomic orientation, the transducer artifact is imaged at the bottom of the screen. This is adjacent to the posterior wall of left ventricle. The posteromedial and anterolateral popliteal muscles are viewed from apex toward base. The ventricular septum and right ventricle are to the left of the image. The anterior wall is furthest from the transducer. This particular view is used to monitor left ventricular function during high-risk cardiac surgery. In the long axis projection or longitudinal view, the transducer is posterior to the posterior wall of left ventricle. The mitral apparatus and its support are visualized in long axis. The anterior wall and posterior wall are respectively visualized along with left atrial cavity. The next animation is that of the longitudinal views from the mid-esophageal transducer position. Biplane scopes are utilized. These are best appreciated as sagittal views imaged from the left. There's the left atrial view, the right ventricular outflow view, aortic view, and superior vena cava view. From the aortic view, long axis and short axis projections are obtained by lateral and medial flexion of the transducer. Going full lateral, the transducer can be carried off through the pulmonary veins to the descending thoracic aorta. On the right side of the heart, when the scan is carried off the heart, it images the right pulmonary veins. This specimen has been cut in the longitudinal view. As imaging from the left side of the heart, the esophagus is posterior to left atrium. The mitral valve is visualized in the superior portion of the left atrium. Left atrial cavity is visualized beneath the mitral valves. The anterior and posterior wall of left ventricle are respectively imaged. In the atrioventricular groove, the coronary sinus, anteriorly in the left atrial cavity, the left atrial appendage, and the left upper pulmonary vein. Anterior to the left upper pulmonary vein is the left pulmonary artery. These sections can be sequentially imaged from left to right in the heart. In the longitudinal plane, 4 basic views are obtained as illustrated on this composite image. First is the left atrial view, in which the left atrium is visualized adjacent to the transducer, anteriorly the left atrial appendage, the mitral valve, and left ventricle. By rotating the transducer rightward, the right ventricular outflow view is obtained. Transducer is adjacent to left atrium, and far anterior is the right ventricular outflow tract, pulmonary valve, and main pulmonary artery. An oblique section of the left ventricular outflow tract is visualized in between. Further rightward rotation visualizes the aortic view. The transducer is adjacent to left atrium, anteriorly are the aortic cusps, the ascending aorta, the left ventricular outflow tract, anterior leaflet of mitral valve, ventricular septum, and the right ventricular outflow tract. This is akin to a parasternal long axis view of the aorta. Still further rightward rotation results in the superior vena cava view. The transducer is adjacent to left atrium. The atrial septum separates right atrium from left atrium. Inferiorly is the inferior vena cava, which can be traced up to the superior vena cava in long axis. Anteriorly is the right atrial appendage. These are the 4 basic views obtained from the longitudinal projection from mid-esophagus. The next sequence illustrates these longitudinal views. First is the left atrial view, which left atrium is posterior, mitral valve, and left ventricle. The next view is the right ventricular outflow view, with the right ventricular outflow anteriorly cut in long axis, the main pulmonary artery, an oblique section of the left ventricular outflow tract. The left atrium is posterior. With further rightward rotation of the transducer, an oblique section of the ascending aorta is the primary structure. The ascending aorta is cut in long axis. Posteriorly is left atrium. The right pulmonary artery is cut in short axis, posterior to the ascending aorta. A portion of the atrial septum separates right and left atrium. Superior vena cava is the next view by progressive rightward rotation of the transducer. Superior vena cava and long axis goes through right atrium and can be projected down into the inferior vena cava. The sequence will be shown in real time. These progressive longitudinal views are obtained by rightward rotation of the transducer across the sagittal planes of the heart. The four basic views are obtained in sequence: left atrium, right ventricular outflow, aorta, and superior vena cava. The next sequence is a longitudinal scan in a patient with mitral stenosis and rheumatic heart disease. This is an extremely slow scan, scanning from left to right. In the lateral left atrial cavity, one can visualize the upper and lower pulmonary vein, and superiorly a portion of the distal left pulmonary artery. As the scan is rotated progressively rightward, the partition between atrial appendage and superior pulmonary vein are visualized. The left pulmonary artery is visualized superior to the atrial appendage. This progressively turns into the main pulmonary artery. The transducer posteriorly is adjacent to the left atrium. At the apex of left atrium is the mitral valve, which in this patient is stenotic. Below the mitral leaflets, left ventricle. The ventricular septum separates right and left ventricle and the right ventricular outflow tract. Further rotation results in the long axis of the ascending aorta. This is akin to a peristernal long axis view of the aorta. Posteriorly is the left atrium. Anteriorly, the long axis of the ascending aorta. As the transducer is slowly rotated rightward, portions of the superior vena cava come into view. The superior vena cava will be imaged in long axis and will enter the right atrial cavity. Notice portions of the tricuspid valve are visualized. Anteriorly, the right atrial appendage. The atrial septum separates left atrium from right atrium. Notice the valve of the fossa vallis in the mid portion of the atrial septum, with the superior fatty limbus of the atrial septum appearing as more hyperrefractile thickened portions of the septum. In the right atrial cavity is the eustachian valve, which appears as an undulating membrane. Superior to left atrium is the right pulmonary artery cut in short axis. As the transducer is rotated to the extreme portions of the right atrium, the superior pulmonary veins are visualized. To further illustrate this imaging sequence, the transducer will be rotated from right to left. This is the long axis superior vena cava view. The long axis superior vena cava, the distal right pulmonary artery superior to the left atrial cavity. With leftward rotation, the long axis of the ascending aorta, the distal portion of the right pulmonary artery are visualized posterior to the ascending aorta. As the scan is carried further leftward, the long axis of the right ventricular outflow tract is visualized, and yet further leftward rotation, the left atrial appendage, the partition between the upper pulmonary veins and atrial appendage, and the left pulmonary artery are visualized. The left upper and lower pulmonary veins are visualized with far leftward rotation. With rotation off the heart, the long axis of descending thoracic aorta is visualized. The next animated segment is the visualization of the thoracic aorta and the technique to image that structure. The thoracic aorta lies adjacent to the esophagus. By turning the transducer posteriorly and to the patient's left, the thoracic aorta can be imaged sequentially. The transducer can be advanced below the diaphragm. Withdrawal of the transducer results in sequential short-axis views of the aorta up through the ascending aorta and aortic arch. This can be repeated by advancing the transducer through the esophagus and imaging the thoracic aorta down into the stomach. Longitudinal views can also be obtained with the same maneuver. Sequential long-axis views of the descending thoracic aorta, aortic arch, and ascending aorta can be obtained with this maneuver. This is a transesophageal echo of the mid-thoracic aorta. The transducer is intimately adjacent to the aortic orifice. Posteriorly is the vertebral body. Note that the azygous vein lies just posterior to the aorta. Longitudinal views can be obtained with biplane transesophageal scopes. Color flow can assist in imaging the movement of blood within the thoracic aorta. The combined short and long axis views of the aorta greatly increase the diagnostic capability of this technology. The remainder of this videotape series deals with major unique applications of transesophageal echocardiography. The first application is the clinical assessment for source of embolism. The first example of thrombus is in a 64-year-old female with mitral stenosis. In this basal short-axis view, the superior vena cava, aorta, and pulmonary artery are visualized. Within the left atrium and the left atrial appendage are multiple thrombi. These could not be visualized by precordial echo. The next example of thrombus visualization is in a 74-year-old man presenting with clinical pulmonary embolism. The right atrial cavity is visualized, the tricuspid valve, and right ventricle. Within the right atrial cavity is an undulating, multifaceted mass consistent with peripheral embolization of thrombus. The thrombus was adherent to the eustachian valve and was captured in right atrium. On basal short-axis views of the aorta and pulmonary artery, progressive antiflexion of the transducer allowed imaging of the right main pulmonary artery. As this scan was carried to the patient's right, notice that there is a mass in the distal right pulmonary artery just posterior to the superior vena cava. Investigators have reported the utility of transesophageal echocardiography for the visualization of proximal large pulmonary emboli. The next example is that of spontaneous contrast effect in a 50-year-old female with mitral stenosis. In the basal short-axis view, the aorta, proximal left coronary artery, and atrial appendage are simultaneously visualized. Note in the apex of the left atrial appendage that there is visualization of blood or spontaneous cavitation effect. This is indicative of low output state or the sludging of blood and has a higher incidence of systemic embolization. The next unique application of transesophageal echocardiography is identification of the patent foramen ovale for source of embolism. This is a frontal four-chamber view with visualization of left ventricular outflow tract, portions of the mitral valve, and the atrial septum. Note in the membranous portion of the atrial septum with color flow Doppler, there is turbulence within the valve of the fossa ovalis. This is indicative of shunt through a patent foramen ovale. These patients are presumed to have a higher incidence of paradoxical embolism. Contrast echocardiography can also assist in the detection of right to left shunt. In the overall assessment of patients with source of embolism, the thoracic aorta should be assessed for atherosclerosis. This is an example of a patient with severe aortic atherosclerosis. Notice the nodular appearance to the mid-thoracic aorta. Many of these nodules appear to undulate on their surface, consistent with thrombus. Aortic ulcerations can be recognized by the transesophageal echocardiogram. More importantly, as the scan is taken toward the aortic arch in this particular patient, small endothelial excrescences or pedunculated masses will be visualized. Endothelial irregularities should be considered a potential source of embolism. Note as the scan is taken into the ascending aorta that a mobile pedunculated mass will be visualized. This atheromatous thrombus is considered a potential source of embolism This is frequently observed in patients with severe atherosclerotic disease of the aorta. The next unique clinical application of transesophageal echocardiography is the assessment of the prosthetic valve, particularly the mitral prosthesis. The first example is that of a 62-year-old man with mitral prosthesis and clinical deterioration. On the frontal four-chamber view, medial to the sewing ring of the prosthesis, there is a thin perivalvular regurgitant jet. As the scan is taken further laterally, the ball is seen within the cage prosthesis. There's a small, normal regurgitant jet or closing volume. With further lateral rotation of the transducer, a larger regurgitant jet is visualized. This large jet fills the left atrial cavity and washes back into the left upper pulmonary vein and is consistent with severe mitral regurgitation. The next example is that of a 72-year-old man with a mitral heterograft. The transthoracic examination is shown for comparison with the transesophageal echocardiogram, which will follow. Note that the left atrium is free of obvious echoes. The transesophageal echocardiogram was performed because of increasing Doppler velocities across the prosthesis, suggesting stenosis. On a transesophageal frontal four-chamber view, impressive amounts of thrombus are visualized in the left atrial cavity. These were missed by the transthoracic exam. Notice the relative immobilization of the heterograph cusps, consistent with stenosis. The next most frequent clinical application of transesophageal echocardiography is the assessment of native valve dysfunction, in particular mitral regurgitation, and their causal pathology amenable to valve repair. This is an example of a 56-year-old female with mild mitral and tricuspid valve regurgitation. On a frontal four-chamber plane, the mitral valve leaflets appear somewhat thickened and myxoid. With color flow Doppler, there is a single central jet of mitral regurgitation which is assessed to be mild. The tricuspid valve also shows a small regurgitant jet. This is an example where biplane transesophageal echocardiography will be superior in the delineation of the degree of mitral regurgitation. Note that there are single jets in this horizontal scan. This is a sagittal view of the left atrium in the longitudinal plane. Left atrial appendage is anterior, mitral leaflets, and left ventricle are visualized. With color flow Doppler, there is an additional jet visualized, which exits the posterior mitral annulus and laminates along the posterior wall of left atrium. Complete imaging of the mitral valve is best accomplished with a biplane transducer in order to visualize multiple regurgitant jets. The next example is that of a 69-year-old female with clinically severe mitral regurgitation in whom the precordial echo could not adequately assess the degree of regurgitation. Note that the valve leaflets are thickened, the left atrium is markedly dilated, there's calcification in the mitral annulus, and there's lack of coaptation of the posterior leaflet of mitral valve. With color flow Doppler, there is severe regurgitation of the valve. There are two jets, both coming from the posterior leaflet of mitral valve and totally opacifying the left atrial cavity. This is severe mitral valve regurgitation. This is an example of a patient being considered for mitral valve repair versus replacement. On transesophageal echocardiography, there is obvious prolapse of the posterior leaflet of mitral valve. The left atrium is only moderately increased in size. The left ventricle is hyperdynamic. Note that portions of the mitral valve support apparatus flail into the left atrial cavity. The posterior leaflet lacks coaptation with the anterior leaflet and should be associated with severe regurgitation. Note that the regurgitant jet laminates along the posterior wall of the aorta, consistent with a posterior mitral valve leaflet prolapse. This clinical picture is consistent with a valve suitable for mitral valve repair. as opposed to replacement. This is the intraoperative echo of the same patient following repair of the prolapsing posterior leaflet. Notice that the leaflet has been plicated and that there is adequate coaptation from the anterior leaflet. Intraoperative transesophageal echocardiography assists in determining the adequacy of the mitral valve repair. With color flow Doppler, there is no regurgitation during systole. This is a diastolic frame showing the lack of opacification of left atrium, a very successful repair. This next example shows the utility of biplane transesophageal echocardiography in the assessment of aortic valve regurgitation. This is a frontal four-chamber view of the mitral valve, left ventricle, and left ventricular outflow tract. Notice that the aortic annulus is slightly dilated. With color flow Doppler, there is a regurgitant jet from the aortic valve which laminates along the undersurface of the anterior leaflet of mitral valve. This appears to be a moderate-sized regurgitant jet. This is a longitudinal imaging plane with a transducer adjacent to left atrium. The short axis of aortic cusps are visualized. Anteriorly, the right ventricular outflow tract. The left, right, and non-coronary cusps of the aorta are visualized in short axis. Note that the regurgitant jet occupies a small portion of the left ventricular outflow, consistent with mild aortic valve regurgitation. Biplane transesophageal is superior to monoplane for the assessment of aortic regurgitation. The transesophageal echocardiography has now assumed an essential role in the clinical evaluation of endocarditis, particularly for recognition of vegetations and associations such as abscess. This is a 58-year-old man with questionable aortic valve endocarditis and bacteremia. Precordial echo was unsuccessful in visualizing vegetation. However, on esophageal scanning, there is an obvious pedunculated vegetation in the left ventricular outflow tract. On M mode, this vibrating echo is seen within the left ventricular outflow tract. Color flow Doppler shows severe aortic valve regurgitation. The next example is a 56-year-old female suspected of endocarditis. However, the precordial echo had been inadequate. On transesophageal echocardiography, large pedunculated vegetations are visualized on the posterior leaflet of mitral valve. This was associated with moderately severe mitral valve regurgitation. These were followed closely. However, because of increasing regurgitation, valve replacement was ultimately required. The next is a 75-year-old male with presumed aortic prosthetic valve endocarditis. On transesophageal echocardiography, there is an evident pulsatile mass on the posterior sewing ring of an aortic prosthesis. This is most consistent with a perivalvular ring abscess. This complication had been unrecognized by many other imaging modalities. The world's literature now confirms that transesophageal echocardiography is the technique of superior choice for the assessment of perivalvular ring abscess. Note that there's a small undulating mass in the left ventricular outflow tract consistent with vegetation. The mitral valve appears to be free of endocarditis. Note on color flow Doppler that there is turbulent blood filling the abscess cavity, consistent with a sinus tract. There is also mild mitral valve regurgitation. On a magnified view, the undulating vegetation in the outflow tract is visualized, the expansile abscess cavity, and with color flow, the turbulence of blood within that abscess cavity. Next example is that of a 78-year-old man post-endocarditis and a presumed cure. This patient had an abnormal precordial echo, and transesophageal echocardiography was performed to assess the abnormality. Note that there is a large ovoid mass posterior to the aortic cusps. This mass projects into the left atrial cavity. Within this ovoid mass, there is thrombus. There appears to be systolic and diastolic expansion of this cavity. On magnified view, the cavity is clearly adjacent to the aortic valve cusps. On color flow Doppler, there's a jet of blood from the aortic root into this cavity. This is most consistent with a pseudoaneurysm of the aortic root secondary to endocarditis. This complication is easily recognized by transesophageal echocardiography. This patient also had moderate aortic valve regurgitation. M-directed color shows a diastolic jet consistent with a communication between aorta and the pseudoaneurysm. These findings were subsequently confirmed at corrective surgery. Transesophageal echocardiography has markedly extended the application of the echocardiographic technique for the assessment of tumors and masses. Primary and secondary tumors are better assessed by biplane transesophageal echo. This is an example of a 50-year-old man who had presented for source of embolism. On horizontal echocardiography in the four-chamber plane, note that there is an undulating mass in the left atrium. The exact attachment of that mass is not well elucidated. This is the longitudinal imaging plane with a transducer adjacent to left atrium. The fatty and thin portion of the atrial septum are visualized separating left and right atrium. Note that this undulating pedunculated mass is clearly attached to the valve of the fossa ovalis and extends into the left atrial cavity. This is an example of a 52-year-old male 20 years post-ventricular septal defect repair with an unexpected mass found in the left ventricular outflow tract. This is a frontal four-chamber view. There's a ventricular septal defect patch repair, and the mass is visualized in the left ventricular outflow tract. This man had had documented endocarditis of the tricuspid valve a number of years prior to this examination. The mass in the left ventricular outflow tract was an unexpected finding, but thought to represent old vegetation. This is a longitudinal scan of the left ventricular outflow tract. The transducer is posterior to the left atrium. The long axis of the ascending aorta is visualized. Aortic valves, septal defect repair, ventricular septum, right ventricular outflow tract, left ventricle, and in the left ventricular outflow tract, the mass is visualized. In real time, this mass undulates below the aortic cusps. There's also a smaller mass at the superior margin of the ventricular septal defect repair under the aortic valves. At the time of surgery, these masses were found to be fibroblastomas or papillomas, benign tumors. There were also old vegetations on the tricuspid valve which did not need surgical attention. The next example is that of a 66-year-old female found to have an unsuspected mass in the left atrium. This is a frontal four-chamber view. The left ventricular outflow tract, left ventricle, and mitral valve are visualized. In the left atrial cavity is a large mass with an undulating extension of that mass through the mitral valve orifice. This solid tumor appears to fill nearly most of the left atrial cavity, particularly the medial portions of the left atrial cavity. This is a four-chamber left ventricular outflow view. This is the aortic valve, and the tumor mass appears to arise from the right upper pulmonary vein. This observation is highly suggestive that this is a malignancy extending from the pulmonary vein into the left atrial cavity. Note that on color flow Doppler, the right upper pulmonary vein appears to be partially obstructed by this mass, confirming its malignant origin. Because transesophageal echocardiography can be performed rapidly at bedside without contrast medium, this technology has increased as a diagnostic procedure for aortic dissection, aneurysm, and atherosclerosis. This first example is that of a 58-year-old man with a chronic aortic dissection. This is a mid-thoracic aortic view in the horizontal plane. there's a dissecting membrane which localizes a true lumen centrally and a false lumen posteriorly and anteriorly. Within the false lumen, there is spontaneous contrast effect consistent with lower flow and lower pressure blood. Note there is communication between the anterior false lumen and posterior false lumen. The thoracic aorta is not appreciably increased in dimension, and the true lumen is compressed centrally. With color flow Doppler, there's communication between the true lumen anteriorly into the false channel, and then in circles laterally into the posterior false lumen. This is the longitudinal scan of the same patient. The true lumen is central, and the false lumen closest to the transducer. Biplane transesophageal echocardiography is extremely helpful in elucidating the variable anatomy of aortic dissection. The next example is that of a 51-year-old male with an acute type 1 aortic dissection. In the frontal four-chamber plane, the left ventricle, left ventricular outflow tract, aortic cusps, and proximal ascending aorta are visualized. Within the ascending aorta, there appears to be an intimal dissection. Multiple projections are necessary to further elucidate the extent of this dissection. This is a longitudinal imaging plane with the transducer adjacent to left atrium and visualization of the proximal ascending aorta, right pulmonary artery, right ventricular outflow tract. Within the ascending aorta, there appears to be a dominant membrane consistent with that of an intimal dissection. There appears to be communication with the false lumen anteriorly. The dissecting membrane begins close to the orifice of the right coronary artery. Type 1 dissection is also visualized in the descending thoracic aorta. The azygous vein is visualized posterior to the true lumen, and the false lumen is located anteriorly. The overall dimension of the aorta is not increased. This is a longitudinal view of the ascending aorta. The transducer is closest to the false lumen. The true lumen, identified by color flow imaging, shows the more rapidly moving blood flow. The next example is that of a 62-year-old man with aortic regurgitation and aortic root aneurysm. Transesophageal echocardiography was performed to exclude dissection. Note that the aortic cusps are dilated. The left ventricle appears to be hyperdynamic. There is no obvious dissecting membrane in the ascending aorta. With color flow Doppler, there is severe aortic valve regurgitation. On complete transesophageal echocardiographic evaluation, the aneurysm was confined to the ascending aorta, and there was no dissecting membrane. Coronary arteriography was performed preoperatively, but other imaging modalities were not performed. The transesophageal echocardiographic results were confirmed at surgery. This next example again shows the utility of transesophageal echocardiography for the delineation of aortic atherosclerosis. Note the undulating membrane or thrombus in the descending thoracic aorta. In these severely involved patients, this observation can be quite impressive, as in this patient. This extensive degree of atheromatous plaque and undulating masses is frequently called a coral reef aorta and has serious clinical implications. Usually surgical removal or replacement of the aorta is necessary. Commonly, the atheromatous thrombus is small and beyond the resolution of computerized tomography, magnetic resonance, or angiography. Transesophageal echocardiography highlights these undulating masses. Examination of the aorta for atherosclerotic change should be a routine part of every transesophageal examination. Because transesophageal echocardiography can be moved conveniently to the bedside, and obtains predictably high-quality images, application in the critically ill patient has been one area of great expansion of this new technology. Even in the intubated or hemodynamically unstable patient, transesophageal echocardiography can be performed expeditiously and safely. The first example is that of an infarct complication in a 70-year-old man. On transesophageal echocardiography in the transgastric position, the transducer is closest to the posterior wall of left ventricle. The anterior wall is anterior. Near the posterior wall and closest to the transducer, there is an echo-free space. There's a communication between the left ventricular cavity and this free space consistent with a life-threatening pseudoaneurysm, or rupture of the free wall of left ventricle. With color flow, there's communication of blood between the left ventricular cavity and the aneurysm. This life-threatening complication has been repeatedly identified by transesophageal echocardiography, which has now become an extension of the diagnostic procedures in the coronary care unit. This particular small pseudoaneurysm was documented and confirmed at surgery. This infarct complication occurred in a 57-year-old male who presents with pulmonary edema. The patient is intubated and in marked congestive heart failure. Note on transesophageal echocardiography that there's an undulating mass attached to the posterior leaflet of mitral valve. This represents an infarction of the posteromedial papillary muscle and partial rupture of the papillary muscle head with the production of severe mitral valve regurgitation. Note that the left atrium is not appreciably dilated and is consistent with the acute nature of the mitral regurgitation. With color flow Doppler, there's severe mitral valve regurgitation consistent with a prolapsing posterior leaflet. This patient underwent emergent surgery and replacement of the mitral valve. The next application of transesophageal echocardiography is in trauma, particularly in the emergency room. This is a 58-year-old man involved in an auto accident and suspected of having severe internal injury. Transesophageal echocardiography shows the descending thoracic aorta in horizontal scan. The mid-thoracic aorta appears intact. However, as the transducer is withdrawn, there appears to be an external hematoma and then an actual rupture in the aortic wall. A portion of the wall undulates between the true lumen and the external hematoma. On the basis of this transesophageal echocardiographic observation, the patient was taken directly to the operating room. Unfortunately, because of the extensive nature of the trauma, the patient did not survive. However, this example does illustrate the utility of transesophageal echocardiography for the rapid recognition of cardiovascular trauma. Another clinical application of transesophageal echocardiography is the assessment of congenital heart disease. To date, because of the size of the transesophageal transducer, this application has been primarily in the adult patient. Anomalies which have shown unique application to the transesophageal technique are shown on the subsequent video segments. This first example is a 34-year-old female with large right-sided chambers and a suspected atrial septal defect. Because of exogenous obesity, precordial echocardiography was insufficient. In this four-chamber transesophageal view, the atrial septum appears to be thin in its mid-portion. However, an actual defect is not visualized. The right-sided chambers appear enlarged. This is particularly notable on the transgastric view. Note the normal-sized left ventricle and the large right ventricular cavity. There's paradoxical ventricular septal motion consistent with volume overload. On views specifically designed to visualize the atrial septum, there is a large secundum atrial septal defect. There's communication between right and left atrium. Note that the right ventricle is modestly increased in size. There's a small tag of tissue on the superior limbus of this large secundum atrial septal defect. With color flow Doppler, left-right shunting is clearly visible. In a patient with volume overloaded right-sided chambers, further documentation is usually not necessary preoperatively. The second example is that of a primum atrial septal defect, again in a young woman who had technically poor precordial echocardiography. Note that the atrioventricular valves are inserted downward, consistent with the AV canal defect. At the lower atrial septum, there is a small defect consistent with a primum atrial septal defect. This particular anomaly is usually easily imaged from the precordial exam. Note with color flow Doppler that there is left to right shunting across this defect. This patient had volume overloaded right-sided chambers, and further documentation preoperatively was not necessary. The next example is that of a sinus venosus atrial septal defect. Precordial echocardiography can diagnose this defect in only approximately 70% of patients. This is a frontal four-chamber view of left and right atrium. Note that the valve of the fossa vallis is thin and mobile. Trabeculations of the right atrium are a normal observation. As the transducer is withdrawn from the esophagus in the superior atrial septum, there is a defect consistent with a sinus venosus atrial septal defect. Note there's a catheter in the superior vena cava. The sinus venosus defect is a deficiency in the atrial septum between superior vena cava and left atrium. With superior withdrawal of the transducer, at the level of the right pulmonary artery, there is an anomalous vein entering the superior vena cava. The right pulmonary artery is posterior to the superior vena cava. With color flow Doppler, the anomalous connecting pulmonary vein is visualized in the lateral wall of the superior vena cava. Discrete subaortic stenosis is occasionally difficult to appreciate by precordial echocardiography. This is the case in this 22-year-old female. This is a four-chamber view. Note that in the left ventricular outflow tract, just inferior to the aortic cusps, there's a thin, discrete membrane. These obstructing membranes can be difficult to visualize by precordial echocardiography. Transesophageal echocardiography, in particular biplane techniques, clearly elucidate these obstructing membranes. Note that the left ventricular myocardium is increased in thickness consistent with hypertrophy. There's also systolic anterior motion of the mitral valve consistent with outflow obstruction. Transesophageal echocardiography is highly sensitive for the visualization of membranes within the left atrial cavity. A form fruste of quarter atriatum is shown in this example, cut in the frontal four-chamber view. Note there's a membrane in the left atrium coursing from the superior margin of the fossa vallis to the partition between the atrial appendage anteriorly and the left upper pulmonary vein posteriorly. With color flow, blood emanating from the left upper pulmonary vein is clearly visualized posterior to the membrane. The left atrial appendage is anterior to the membrane. With retroflexion of the transducer into the four-chamber plane, this membrane will be visualized attaching to the superior margin of the fossa vallis, crossing the atrial cavity, and attaching to that partition between the pulmonary vein and the atrial appendage. In this particular patient, the membrane had multiple fenestrations and was incomplete and non-obstructive. This is a benign observation and should not be confused as a source of embolism or other important pathology. Note that the mitral valve leaflets are moving normally. Another expanding clinical application of transesophageal echocardiography is its use intraoperatively, particularly for the assessment of mitral valve repair, but also for myectomy, the visualization of ventricular function, air and fat embolism, and repair of congenital cardiac defects. This is an example of a 58-year-old female undergoing mitral valve repair. This intraoperative transesophageal echocardiogram shows prolapse of the anterior leaflet of mitral valve. Note that portions of the leaflet are either flail or partially flail. Segments of chordae are visualized in the left atrial cavity. Left ventricular function is normal to hyperdynamic. The left atrium is moderately increased in size. On magnified view, there's thickening and distortion of the anterior leaflet of mitral valve. In addition to these observations, the mitral annular diameter is measured to help the surgeon determine the necessity of ring prosthesis. And secondly, the degree of mitral valve regurgitation and its morphologic features are assessed by color flow Doppler. Notice in this patient with prolapsing anterior mitral valve leaflet that the regurgitant jet laminates along the lateral and posterior aspect of the left atrial cavity. This is severe mitral valve regurgitation. This composite video shows the preoperative assessment to the left and the postoperative assessment to the right. Notice in the postoperative state that the anterior leaflet is moving more normally than the prolapsing preoperative assessment. Following chordal transfer, the coaptation appears to be much more satisfactory. Transesophageal echocardiography can rapidly identify these morphologic features as well as associations. With color flow Doppler, note that there is only trivial residual mitral valve regurgitation. There is also no left ventricular outflow obstruction. The next is an intraoperative transesophageal echocardiography in a 43-year-old male undergoing myectomy for hypertrophic obstructive cardiomyopathy. Note that the upper ventricular septum is hypertrophied and that there is systolic anterior motion of the mitral valve consistent with an obstructive myopathic process. Left atrium is moderately increased in size. On color flow Doppler, there is severe mitral valve regurgitation as frequently accompanies this particular cardiomyopathy. Mitral regurgitation can either be a primary or a secondary phenomenon. The secondary phenomenon is caused by the distortion of the mitral support apparatus and secondary regurgitation. This is usually cured by myectomy. This is an echo in the same patient post-myectomy. Note the large segment of septum that's been removed. With color flow Doppler, there's only a small residual mitral regurgitation. This confirms that the severe mitral regurgitation noted preoperatively was a secondary phenomenon. The next example is the monitoring of left ventricular function during an aortic aneurysm repair. The patient has coronary artery disease and a cross clamp of the aorta has been applied. In this transgastric short axis view, note that with a cross clamp there is a wall motion abnormality in the infraapical septum. The image is oriented such that the posterior wall is to the top of the image. This wall motion abnormality would be consistent with an ischemic injury to the heart. Following release of the cross clamp, note that the wall motion returns toward normal. This indicates less ischemic stress in the myocardium and allows the surgeon and anesthesiologist to better manage this type of patient. Intraoperative monitoring with transesophageal echocardiography has become a routine extension of this new technology. The next example is a 68-year-old female who is immediate postoperative aortic valve excision. Upon returning to the intensive care unit, the patient was in shock and hypovolemic. The question of tamponade or infarction were clinical considerations. However, transesophageal echocardiography immediately shows that the volume of the ventricle is markedly decreased, consistent with hypovolemia. This clinical situation was rapidly reversed with fluid replacement. Intraoperative transesophageal echocardiography is also being used by neuro and orthopedic anesthesiology to monitor air or fat embolism. These particular images were provided by Dr. Mark Areth and Martin Abel of our Department of Anesthesiology. This is an orthopedic patient, and notice with implantation of the hip prosthesis, there's a large fat embolus appearing in the right atrial cavity. Air and fat are common complications of upright neurosurgery and orthopedic surgery. This is a most interesting observation and one that directly impacts on clinical management of these patients. Notice the fine particulate air in the right atrium, as well as this large undulating mass consistent with fat embolus. This patient did have postoperative hypoxia. This last example is the clinical utility of transesophageal echocardiography in the assessment of congenital heart disease. This was a 67-year-old female presenting with secundum atrial septal defect. Note the surgeon's finger across the atrial septal defect. This unique visualization of the surgical field is particular to transesophageal echocardiography. Note that there's a small aneurysm of the valve of the fossa ovalis, which undulates with each movement of the heart. The surgeon has his finger across the defect for a second time. Monitoring esophageal echocardiography gives a unique insight into the repair of congenital heart disease. This is the postoperative view in the same patient. Note that the defect has been closed with an atrial septal patch. The patch is intact and appears well adherent to the sewing margins. In conclusion, the Echo Laboratory now is a cardiovascular ultrasound imaging and hemodynamic laboratory. A complete laboratory is more akin to a cardiac catheterization laboratory. A complete examination can now be performed all the way from an adult through the unborn fetus. In addition to the outpatient examination, intraoperative, outreach, and emergency application of imaging and hemodynamic data are applied. Examinations which are similar to those obtained in the cardiac catheterization laboratory include imaging, which is usually accomplished with two-dimensional echocardiography. Functional assessment is with two-dimensional Doppler examination. Non-invasive hemodynamics include the calculation of gradient, flow, pressure, and valve area. Color flow Doppler can be looked upon as a substitute for angiography for the assessment of valvular regurgitation and shunts. A comprehensive, non-invasive imaging and hemodynamic laboratory now accomplishes many procedures, some of which have been discussed in this video series. We now routinely perform contrast echocardiography, outpatient and intraoperative transesophageal echocardiography, pericardiocentesis, stress echocardiography, and now invasive intravascular echocardiography.